Nice to see you all. I guess we were invited because in the past we've done a lot of work with trachoma and leprosy and neglected tropical diseases on the mass media side. Both when I used to run the BBC World Service Trust's, what is now called BBC Media Action's Health Division, and then now at DMI. And I have to say, I would like to congratulate the NTD community, because these mass drug administrations and the way you're reaching national populations, when I was working in 2002, 2003, you were reaching sort of 200, 300,000 people at a time, and now you're reaching entire populations and really getting towards eliminations. That's a huge difference, and it's making use of, instead of the White Land Rover Brigade, you're making use of national health systems, which is just a real achievement. So DMI, Development Media International, the reason why we exist and what we try to do is to take the proposition that mass media can help change behaviours and try and locate it within the public health community. I'm sure anybody working in the creative industries will find a certain frustration that when you're at public health conferences, there's always a real dislocation. You're always slightly at the edge. You're just not part of the mainstream. And the mainstream is, for very good reasons, drugs, doctors, hospitals, nurses. Various interventions are established and tested. And if you think about how about how public health is run around the world, it's run by public policymakers who are trained as epidemiologists or they're trained as health economists. And the sort of evidence that they're used to, the hard-nosed evidence that they're used to, is things like randomized controlled trials and real hard evidence. And they're used to sort of lots of it. And for that reason, creative types who say, look, this is good, this is fun, this makes a big difference, don't get taken very seriously. And yet, we're talking about, just take for an example, a mother who's got a child and the child's got diarrhea, and every time she gives the child food or water, it comes out the other end. And the mother can completely plausibly conclude that she's causing her child's diarrhea, and that's how 500,000 children die every year. They don't die of the diarrhea, they die of the dehydration that's caused by the diarrhea. And so it seems plausible then, well, it seems only right that this mother, and mothers are the most highly motivated things that we know of on this earth. I was going to say species, but they're the most highly motivated organisms that we know of in terms of wanting to keep their child alive, and yet it seems a human right that they should just know that basic information. And I guess the proposition that we're making, and I think that the creative community has to make, is that it's not just a human right, it's not just a good idea, it's actually a really efficient way of saving lives. Because I think we're up against, I think the contention of the other side will always be that, well, why are you spending precious money making entertainment programs? How can you justify that then when the people haven't got enough water, people haven't got enough drugs, people haven't got enough doctors, people are, there's 200 people in a classroom in Burkina Faso I went to recently. The basic necessities are so pressing and so strong and so evaluated that why should we be spending precious funds, precious development funds on entertainment? And so I guess that's the reason DMI exists and the question we set out to answer. So the first thing we did was set up a board stuffed full of all the great and the good of public health, because we knew on the creative side we didn't feel I have a BBC background, many of my staff have a creative or BBC background. We didn't feel any need to justify ourselves at a creative level, but what we really did need was people who were well known and respected within the public health community. So people like David Heyman, who was Assistant Director General of WHO, Joy Pamafi was Vice President of the World Bank, she was Minister of Health of Botswana, Richard Horton, who runs the Lancet, Caesar Victoria, who's the President of the International Association of Epidemiologists, Anne Mills, who is probably the most famous health economist in the world. Various people like this, which we frankly, we stuffed our board full of these people, not people who actually have money. We've got to correct that at some point. We've got to actually get people who have money on our board, but they've been extremely helpful. And then we come to how we actually measure impact. Now, we have this data from the past. We did a sort of quite well-known, when I was still at the BBC, we did a well-known leprosy campaign where we campaigned for 2 one-month periods. And the number of people who believed leprosy was hereditary went down from 56% to 32%, then to 19%. That's about 450 million. The total target population was North India. It was 450 million people, and so we had, you know, well over 100 million people changing their minds. I think it's 119 million people, and we had 200,000 people treated for leprosy. 1 million people turned up to have their skin surveyed, and 200,000 people were actually treated. Now, I love this result. This is one of the campaigns, a long time ago now, and it's one of the campaigns I'm still most proud of. And yet, as scientific data goes, this is lousy. Nobody would take this seriously. I mean, I can tell you that there was almost nothing else going on the mass media side in India at that point. You know, you can call me a liar, but, you know, my word is worth nothing in the scientific community. It's just not the way science is done. How do we know that this is what changed those opinions? Obviously, we didn't treat the 200,000 people. That was the medical system doing that. That was the public health system. So the most that can be said about us is that we changed attitudes and drove people to the skin survey posts. You could argue that, but without any controls or without any other evidence, simple before and after data is really epidemiologically insignificant. Nobody's going to make major funding decisions on the basis of this. We did another leprosy campaign in Brazil, where at the time the number of leprosy patients was outnumbering the whole of Africa. And this is slightly better data, actually, because we measured this on the basis of the number of calls to a leprosy hotline. So that what you see there is the number of calls. In fact, for 6 years before this campaign started, the number of calls to the same leprosy hotline varied between 0 and 10 calls a day. And then suddenly, at the time when the media campaign started, it went up to 600 calls a day. In fact, we got 10,000 calls over that 1 month period before it tailed off and the campaign ended. So that's called time series analysis, and that's actually much more convincing because you haven't just simply got a single variable before and a single variable afterwards. You've actually got the coincidence of a dramatic discontinuity, a dramatic rise in the data with the start of the media campaign. And actually, I think, because I don't think randomized controlled trials are the way forward. We've done one, and we'll do more, but they're incredibly expensive and incredibly difficult. And my personal recommendation for mass media evaluations is this. I think the time series evaluation is really, really good. And one of the reasons it's good is because you can use existing data. Because even if you're just doing a simple survey, you're likely to get stung for 50,000 quid. You know, just for a baseline end-line survey, you can easily spend $100,000, and that's well beyond the budgets of many people. And yet, if you're going to use existing administrative data, such as people reporting to health posts, such as people being treated for certain disease, people having tests. We did a TB campaign in Brazil, and we measured the number of tests taking place in the laboratory. That data was free, and we could do time series analysis and just showing it change. So my recommendation to people who are interested in evaluation is to take time series very seriously. If you want to read more about it, Bob Hornick, who's one of the world's leading evaluators of mass media campaigns, wrote a 2001 book, and the last chapter is when he recommends time series analysis, and he's been advising us, and I think it's good advice. This was a campaign we did in Ethiopia for trachoma. I'm using these examples because they're more related to your own work. And actually, this was the strongest result we ever had. This was conducted by the London School of Hygiene and Tropical Medicine. And the number of people, it was looking at, one of the messages for trachoma was keep your hands and face clean. And we looked at the number of children with dirty hands before and after. One of the dangers when you're evaluating mass media campaigns is that you ask people the question and they'll give you the answer they think you want, and particularly if they've heard a campaign over and over again. I mean, in this case, we broadcast for 3 years, 14 times a day, on keeping your hands clean. I mean, why we didn't measure the number of suicides or people sort of screaming at the radio because I mean that was obviously a risk that we were going to bore people. We did refresh the spots. Obviously, every month we had new spots coming out, and our job was to keep it entertaining, but it was a lot. So rather than ask people, you know, do you wash your hands? Well, they'll certainly know the right answer at the end of a 3-year campaign like that. We were trying to get an idea of actually, did they actually do it? And so we had trained nurses by the London School of Hygiene and Tropical Medicine actually looking and examining people's hands, and that was the result that came out, 74 to 26%. Interestingly, it didn't come down straight away. After 2 years, it had come down from 74 to about 61%. And I remember scratching my head and thinking, what are we doing wrong? Why? Why isn't this working? It's not enough. And I think the answer was that in the 3rd year, it started to become a sort of more social issue, that disapproval of people who were preparing food just after having looked after a kid who's gone to the toilet, you know, was something to be disapproved of. So I think that came in. But I do think that things like hand washing, and this does relate to tropical diseases, I think on the great spectrum of behaviour changes, this is one of the most difficult. If you think of leprosy, actually one of the easiest behaviour changes. It sounds hard. You've got centuries of stigma, and people are, you know, have got very rigid attitudes on leprosy. But what it actually costs you is almost nothing. You've got to get your head around the fact that you've got leprosy, but on the one hand, you can have a disease that's going to wreck your life, versus you take one pill for 6 months and you're done. That's a much easier behaviour change than, the other extreme is condoms, obviously. Condoms, you've got to wear them every time you have sex. You've got to deal with issues of love and infidelity and all these things which complicate HIV, make it enormously difficult. But I would put hand washing really close to that end of the spectrum, because you've got to do it. You've got to do it 6 times a day. You've got to do it every time you have food or change a nappy or whatever for the rest of your life. In this country, people don't do it all the time, and yet we have a ceramics industry. We have piped water. We have hot water. We have towels. We have all these bathrooms, all these things which have been built up over the last century to make hand washing easier, and yet we still don't all do it. So anyway, I think it's a hard behaviour change. The other thing, trachoma prevalence actually went down from 72 to 52%, which was one of the few documented instances of mass media actually having an impact on the prevalence of a disease. A lot of the time, when we measure mass media impact, we're talking about, the amount of people we reach, or the amount of attitudes we change, or even reported behaviour change. But actually impacting on a disease and the numbers who actually have the disease is pretty rare. So anyway, I took some of this evidence to the Wellcome Trust and said, how about giving us lots of money? And they said, how many lives can you save? And I said, I don't know. I have no idea. Isn't that your job? And they said, well, go away and find out. And I teamed up with 2 people, actually. Simon Cousins at the London School of Hygiene and Tropical Medicine, who's a sort of very respected mathematical epidemiologist, and Anne Mills, who's Deputy Director of the London School of Hygiene and Tropical Medicine and is a very, very highly respected health economist. And I barely knew how to use an Excel spreadsheet at the time, and we built up this incredibly complicated mathematical model. And it was quite exciting just being taught by these people. And we spent a year on it, and at the end of it, we came up with a mathematical model which predicted that we could reduce child mortality by quite a bit, and what's more important, we could reduce child mortality at a cost per life saved that was as low as anything else that exists. So on that basis, the Wellcome Trust and the founders of the Lonely Planet travel series, they split the funds between them, and they gave us about £7 million, and we conducted the world's first randomised controlled trial in a developing country to measure the impact of mass media. And I think this is, so we published in The Lancet, we published this model in The Lancet, we published what we thought we were going to achieve, and then we did it in Ouagadougou. Now, let me just explain why this is so hard, and I'm distinguishing this from the absolutely valid study that Georgia talked about, which was showing community screenings. Yes, you can do randomised controlled trials of individuals or small groups. That's relatively straightforward. But what we were talking about here was actually measuring the power of the mass media which can reach millions of people at a time in its natural state. So people just listening to radio while they're brushing their teeth, or they're not being told to go and attend a screening. And this has been attempted 4 times ever, and they've all been in the United States, and they've all failed. And the reason why they failed is, if you imagine that's a map of the United States, well, let's talk about Britain. You can do a randomised control trial in Britain, right? You can broadcast on Radio Stoke, you can broadcast on Radio Luton, you can broadcast on GLR, you can broadcast on Radio Bristol, you can not broadcast on various other radio stations. It would be easy to do a randomised control trial in that way in Britain, right, on local radio stations. But most people are not listening to those radio stations. Most people are listening to Radio 1, Radio 2, Radio 3, Radio 4. They're watching BBC 1 television, BBC 2, BBC 3, BBC 4, ITV. They're watching the major national television stations. So when they did this in the United States, they did it on local media, which was fine, apart from the fact that most people were listening to, watching CBS, NBC, ABC, MTV, Fox, all those PBS, all those channels that are nationally available, and they had to exclude them. So they were effectively measuring a randomised controlled trial, trying to measure the power of the media without giving the media its full power, or anywhere near its full power. So that's been a problem. That's been, the medium is primarily a national medium, and yet you're trying to measure it locally. It doesn't work. Thank goodness Burkina Faso exists. We looked at 100 countries and studied them, and Burkina Faso is incredible. It's a lovely country with lovely people. It's in West Africa, next to Ghana and Mali, and they took a political decision that they would broadcast then on their national radio pretty much only in French. So that's a map of Burkina Faso, and there's 56 languages in Burkina Faso, and people prefer to listen in their own local language. And about 5% of people are listening to national radio, which is great for us. It's politically difficult for the government, but it's great for us. It means that all the power of the media, because there's not much television there either, all of the power of the media was there in the local radio station. So you get, 90% of your radio audience is going to be listening to these local stations. So the blue zones represent areas in which they represent the sort of propagation limits, the circumference of how far the signal's going to reach of stations in Banfor or Solenzo or Sapuy or Borno, these stations that you can see. And the red zones represent the ranges of stations where we didn't broadcast. So what we did for 3 years, it was a sort of massive campaign really. We threw everything in the kitchen sink at it. We broadcast 10 times a day, 365 days of the year, for 3 years, plus 2 hours every night, 5 nights a week. So we had this interactive program going out on radio 5 nights a week, again, all throughout the year for 3 years. And then spots, just, creative drama spots going out on radio. So it was pretty massive. And we had to have a team of about 35 people in Burkina Faso to do that. And we formed partnerships with radio stations. And we measured before and in the middle and afterwards. Now, we're about to publish this stuff, so I'm not going to put it up on the screen, because otherwise we won't get published. But I'll tell you the results. The results are that we had a 35% increase in health-seeking behaviours. So people getting the 3 big killers in Burkina Faso: malaria, diarrhea, pneumonia. Those are the things that kill kids. And in the first year of the campaign, there was a 35% increase in people getting treatment for those things. We also had a 9% increase in people getting antenatal care, and a 7% increase in people delivering in a health facility. Those results are the first, that is the first available proof anywhere in the world that mass media can change behaviours. The interesting question on the how many lives it can save, we didn't, in the survey that we had, we weren't able to detect a reduction in child mortality. The study, I don't know how many of you are statisticians, we were powered to detect a 20% reduction, which is a bit optimistic. It was the best we could do. That it wasn't possible to get any bigger survey. No other design anywhere in the world would have achieved that. And we didn't get a 20% reduction in mortality. What we did get, and what we know this from modelling, from taking those behaviour changes and plugging them into a thing called the LIST tool. It's called the Live Save tool. It's the sort of gold standard model. It tells you if you improve breastfeeding in Botswana by 20%, you'll save 33 diarrhea deaths and 45 measles deaths, or whatever. It adds it all up for you. It was funded by Gates, and for people working in child survival, it's the gold standard. And what that tells us is that we reduce child mortality by about 7.5%. which is actually lower than we wanted. We were hoping for higher than that, but it's still a very significant figure. So I think that's been useful, and we now have, I mean, ostensibly this is about mass media, and this is about the importance of mass media, but really it's not. Really this is about human knowledge and the importance of human knowledge. If you think about why you're healthy today, it's not just doctors treating you every day, is it? There's a lot of knowledge that goes into your own behaviours and nutrition and exercise and preventive and noticing an emergency. And we think that this is a strong argument now why human knowledge should be put at the centre of epidemiology and health economics and public policy. It's not always cheap to do, and we need to work out ways of doing it more and more cost effectively. But one issue I will say is that the cost per life saved puts us at about 15th on the rankings of all health interventions. So if you add up 600 health interventions, we're about 15th down the list. The cheapest way of saving lives that currently exists is childhood immunisations, and that's about $8 for each year of healthy life added. We're about $15 for each year of healthy life added. And HIV treatment, for example, is somewhere up in sort of $600 to $1,400. Just to give you some idea of perspective, in this country we allow drugs that go up to £30,000. So, we're right at the very cheap end. Anyway, that's where we are, and I thought I'd just update you on that.